program. He's going to tell you about anticoagulation and atrial fibrillation. Specifically, over the last 5 to 6 years, we've come to realize not every patient with atrial fibrillation has the same risk. Not every single patient has the same bleeding risk. And then there has been an explosion in anticoagulants. So he's going to cover those 3 topics. And Dr. Nair.
Hi, I'm Krish Nair, originally from Kerala, India, the high radioactive zone. And my topic is oral anticoagulation for atrial fibrillation, who and how. I have no disclosures or conflicts of interest. So the objectives of this talk will be to understand the indications for oral anticoagulation in atrial fibrillation, to discuss some of the scoring systems now in use, like the CHAD-S2 score, and to discuss the guidelines for anticoagulation use in some common scenarios like cardioversion and coronary artery disease. So I've organized a talk like this. We'll go through the need for anticoagulation, the different scoring systems, the different anticoagulants that are available, and then the common scenarios. So why anticoagulate at all in atrial fibrillation? The annual risk of stroke in atrial fibrillation is 5%. 1 in 5 of all strokes is attributed to atrial fibrillation. Mortality with stroke in atrial fibrillation is 3 times higher. And when you look at the effect of the first ischemic stroke in patients with atrial fibrillation, 60% of these strokes are disabling, 20% are fatal. The commonest site for a thrombus in the heart in atrial fibrillation is the left atrial, is the is the left atrial appendage. This is the pathology specimen, and this is a transesophageal echo. So what are the risk stratifying scoring systems in atrial fibrillation? The last Canadian Cardiovascular Society guidelines clearly state that every patient with atrial flutter or atrial fibrillation should be stratified using a predictive index for stroke, like the CHAD-S2 score, and a scoring system for the risk of bleeding, and that most patients should receive some form of antithrombotic therapy. We're all familiar with this scoring system, the CHAD-S2 score. We have 5 criteria, and the maximum score is 6. The only major criteria is prior stroke. The only major criteria is prior stroke or transient ischemic attack, which is allotted a score of 2. And the other criteria are heart failure, hypertension, age, and diabetes. If your score is 0, the adjusted stroke rate is 1.9% per year. If your score is 6, the adjusted stroke rate is 18.2% per year. And the guidelines tell us what antithrombotic to use when. So if the CHAD-S2 score is 0, you're in the low risk, so aspirin or no antithrombotic. If the CHAD-S2 score is 1, oral anticoagulation or aspirin, but oral anticoagulation is preferred. If the score is 2 or more, you're in the high risk, and it's oral anticoagulation always. The CHAD-S2 WASC score is recommended in the European Society of Cardiology guidelines. And what it does is that the 3 more criteria are added, and they are vascular involvement, which is V, A. A is for age. So the CHAD-S2 includes age more than 75. Here there's an additional category that's age more than 65. And SC is for sex category. Female sex is allotted 1 point. So in all, you can have a maximum score of 9. And if your score is 0, you're truly low risk. So the adjusted stroke rate is only 0%. And that's the utility of the scoring system. It helps us to identify the truly low risk category. So the recommendation is that if the CHAD-S2 is 2 or more, anyway you're going to anticoagulate. There's no point in going to the CHAD-S2 WASC. If your CHAD-S2 score is 0 or 1, then you want to identify the truly low risk category. the group of patients who do not require anticoagulation. And it is here that the CHADS2 score helps. So the recommendation is that if your score is 0, no anticoagulation or aspirin. If your score is 1, oral anticoagulation or aspirin. Again, oral anticoagulation is preferred. And if your score is 2 or more, oral anticoagulation. So it's easy to remember because it's exactly like the CHADS2 score in terms of what to do with what score. This is the only scoring system that has really been validated for bleeding in atrial fibrillation. There was a previous scoring system called hemorrhages, which is not well validated. So again, use the same mnemonic: H for hypertension, A for abnormal renal and liver function, 1 point each. S for stroke, B for bleeding, L for labile INRs, E for elderly, that's age more than 65. D, drugs or alcohol, 1 point each. So you can have a maximum of 9 points here. So how does this scoring system help? The guidelines are not clear on exactly how to use this scoring system. But what one can do is, if you have a score of 3 or more, it indicates a major risk of bleeding. So especially for patients who are in the low risk category, when you have difficulty in deciding between aspirin and antiplatelets, if the Hasblad score is 3 or more, probably one can tend towards giving them just antiplatelets. The other important thing is that you can use the scoring system to find out if there's a reversible factor, like high blood pressure which is uncontrolled, or a drug, which is or a drug which can, or alcohol which can predispose to increased bleeding, and you can try and correct that. So what are the antithrombotic drugs that we have now? We are all familiar with Warfarin. So Warfarin works. Warfarin is effective in reducing the risk of atrial fibrillation-related stroke. There are 26 trials which are Warfarin-related. The trials of Warfarin versus placebo show that there's a 64% relative risk reduction in the incidence of stroke related to atrial fibrillation. Antiplatelet versus control, the relative risk reduction is 22%. Warfarin versus antiplatelet agents, there's a 39% relative risk reduction, which means Warfarin is clearly more effective than aspirin. There is an increase in major extracranial bleeding, which is small, less than 0.3% here, but as we all know, the risk of intracranial hemorrhage increases. It's around 1.5 to 1.7% per year. The problem with Warfarin is that only 50 to 60% of eligible patients receive Warfarin because of the problems with monitoring and dose adjustment. Also, for Warfarin to be effective, the INR has to be therapeutic. And in clinical trials, the time in therapeutic range is only 60 to 68%. In general practice, it is typically less than 50%. So what are the new oral anticoagulant drugs that we have? The one that we are all familiar with is Dabigatran, which is a thrombin inhibitor, that is factor 2A inhibitor. There are 3 new medications coming in: rivaroxaban, apixaban, and edoxaban. Dabigatran, the half-life of Dabigatran is 12 to 17 hours. It's predominantly renal excreted, and that is why the drug may accumulate when renal function is abnormal. There is no interaction with food. The anticoagulant effect is predictable. So therefore, the fixed dosing, unlike Warfarin, there's no need for monitoring, and there's no liver toxicity. All the data that we have on Dabigatran is based on one single study, RELY, unlike Warfarin. So this study compared Warfarin with 2 doses of Dabigatran, 110 milligram 2 times daily and 150 milligram 2 times daily. The 110 milligram dose was non-inferior in terms of efficacy to Warfarin. The 150 milligram dose was superior in terms of reducing the combined endpoint of stroke and systemic embolism. I've summarized the results of this trial. So Dabigatran 150 milligram was superior to Warfarin for stroke prevention, reducing the risk of both ischemic and hemorrhagic stroke. The 110 milligram dose was similar to Warfarin for stroke prevention. The 150 milligram dose reduced the risk of cardiovascular mortality. In terms of safety and the bleeding risk, major bleeding was reduced with the 110 milligram dose. The risk of major bleeding was similar with the 150 milligram dose. And what is important is that the risk of major gastrointestinal bleeding was increased with Dabigatran 150 milligram compared to Warfarin. Therefore, if you have a patient who has polyposis or diverticulosis, prescribing Dabigatran is not a great idea. Warfarin is probably preferable. Both doses of dabigatran reduce the risk of intracranial hemorrhage compared to warfarin. In elderly patients and in patients with renal impairment, the recommendation is that renal function should be assessed yearly, and dabigatran is contraindicated in severe renal function. That's a creatinine clearance less than 15 ml per minute. So ideally, renal function should be assessed prior to starting dabigatran. So how do we switch from one anticoagulant to the other? If you wish to switch from warfarin to dabigatran, stop warfarin, let the INR float down to less than 2, and then start dabigatran. How do you switch from a parenteral anticoagulant to dabigatran? If the patient is on a low molecular weight heparin, say enoxaparin 2 times daily, give the morning dose, say at 8 o'clock, and give dabigatran at 6 p.m., 2 hours before the evening dose, and just continue. Suppose you want to switch from unfractionated heparin to dabigatran, stop the unfractionated heparin, and give dabigatran straight away. How do we switch from dabigatran to a parenteral anticoagulant? Because the duration of action is around 12 hours. You'll have to wait 12 hours after the last dose of dabigatran before starting either unfractionated heparin or low molecular weight heparin. How do you convert from dabigatran to warfarin? Because dabigatran is predominantly renal excreted. This depends on the creatinine clearance. For a creatinine clearance less than 15, there's no recommendation because it's not dabigatran should not be given to these patients. For creatinine clearance more than 50 ml per minute, start warfarin 3 days prior to discontinuing dabigatran. For creatinine clearance between 31 to 50, it should be started 2 days prior to discontinuing dabigatran. For creatinine clearance 15 to 30, start warfarin 1 day prior to that. What do you do for patients on dabigatran who are going for surgery? So here again, this is not a standard recommendation. This is from the Boehringer company website. These recommendations, what they say is that essentially you have to decide based on the renal function and the type of surgery the patient is going for and the bleeding risk involved with that type of surgery. So in a patient with fairly okay creatinine clearance, the recommendation is to stop dabigatran for 2 doses. If the creatinine clearance is between 30 to 50 and the bleeding risk is standard, stop dabigatran at least 2 days before, and if it's less, and if the creatinine clearance is less than 30, stop dabigatran 2 to 5 days before. It's available on Google. So, it's not a standard recommendation. That's what I was saying. Yeah. And there's no standard recommendation. But there are standard recommendations for surgical or diagnostic procedures for patients on aspirin and warfarin. For patients at very low risk of stroke, it's common sense that we just stop the antiplatelet agent or warfarin, let the INR come down, and then go ahead with the surgery, and then restart 24 hours later when hemostasis is achieved. Aspirin or clopidogrel, according to the CCS guidelines, should be stopped 7 to 10 days prior to surgery. Warfarin for 5 days if the INR was in the range 2 to 3. What do you do for patients who are at high risk of stroke, like patients with a prosthetic valve or with rheumatic valvular heart disease, or patients with recent TIA or stroke, or a CHAD-ST of more than 3? And also for patients who have a very thrombogenic intracardiac environment, like patients who are post-Fontan surgery. These patients require perioperative bridging. So you stop the oral anticoagulation, start either unfractionated heparin or low molecular weight heparin until 12 to 24 hours prior. Go ahead with the surgery, and once post-procedure hemostasis is achieved, restart oral anticoagulation along with low molecular weight heparin or UFH. There are 3 new trials which have been published in the last 2 years. We talked about the RELY study, which is the dabigatran study. This is the Aristotle study, which is the Apixaban study. And this is Rocket AF, which is published in September 2011 in NEJM. This is related to rivaroxaban. So what are the key features of this new oral anticoagulants? This is all in comparison to dabigatran. The first thing I should say is that they're all different study groups and different inclusion criteria. The half-life of all these agents is short. It's around 12 hours, roughly. Rivaroxaban and edoxaban have an advantage in that they can be given once daily. This slide I just put up to show that the inclusion criteria are different for these different agents, and there is no direct head-to-head comparison in any trial. So the evidence we have is for these, all these agents have been compared to warfarin, and so we have to derive our conclusions based on that data. The ROCKET study on rivaroxaban looked at atrial fibrillation in patients with at least 2 risk factors or prior transient ischemic attack or prior stroke. So it was a high-risk category that they looked at. So it will be incorrect to compare these trials. I've summarized the important points from all these trials. Low-dose dabigatran is non-inferior, but has less bleeding, as we saw. High-dose dabigatran, that is the 150 milligram BID dosing, is superior with similar rates of bleeding, lower cardiovascular mortality. Rivaroxaban is non-inferior to warfarin with similar risk of major bleeding. Apixaban is superior, there's less bleeding, less stroke, less systemic embolization, has lower mortality. But it's a different patient population as compared to rivaroxaban. There are higher rates of GI bleeding, as we said earlier, with dabigatran and also with rivaroxaban. Discontinuation rates for all these anticoagulants is in the range of 20%. One recent concern now is that, is there a higher risk of myocardial infarction with dabigatran? And this is based on this meta-analysis, where it has shown that there's a higher risk of myocardial infarction or acute coronary syndrome with dabigatran as compared to warfarin. But this is a paper which came out this month from the RELY investigators from dabigatran. They have shown that there's an increase in myocardial infarction with dabigatran as compared to warfarin, but this is non-significant. The annual rate of myocardial infarction was in the range of 0.8% with dabigatran and only 0.6% with warfarin. Anticoagulation and cardioversion. We all know this. In patients who have had atrial fibrillation for less than 48 hours and who are hemodynamically unstable, urgent cardioversion. Who are hemodynamically stable, we can go ahead both with pharmacological or with electrical cardioversion. For atrial fibrillation of flutter with duration more than 48 hours, the recommendation is to oral anticoagulate for 3 weeks and then continue anticoagulation for 4 weeks post because of myocardial stunning. In high-risk patients, the patients we described earlier, those with prosthetic valves, CHAT score more than 3, the best thing to do is transesophageal echo and then cardiovert. It's always important to continue antithrombotic therapy for at least 4 weeks post because of the risk of myocardial stunning. What do you do in coronary artery disease? Depends on whether it is stable CAD, acute coronary syndrome, or PCI. In stable coronary artery disease with low risk of stroke, aspirin alone will suffice. If the CHAD-S2 score is 1 or more, just oral anticoagulation monotherapy will suffice. If a patient has had recent acute coronary syndrome and the CHAD-S2 score is less than 1, which means the risk of stroke is low, aspirin plus clopidogrel. If the risk of stroke is high, triple therapy, aspirin, clopidogrel, and warfarin. In PCI, it's exactly the same as acute coronary syndrome. For patients with low risk of stroke, aspirin plus clopidogrel. High risk of stroke, triple therapy. And remember, because just like as we discussed earlier, because of the risk of coronary events, though the data is not robust, dabigatran is not preferred. Warfarin is preferred in coronary artery disease. And just to tell you that there are some smartphone apps. There's a free app, CHAD-S2, which I have on my phone. Hasblood and CHAD-S2 VASC. You have to search for Birmingham calculator to get this. You won't get it otherwise. So in summary, we discussed the need for anticoagulation, the different scoring systems, the different anticoagulants, and we went through all these scenarios. And thank you.